Welcome to Consensus or Controversy, documenting and discussing clinical investigators' practice patterns in myelofibrosis. And of course, this is a CME Satellite Symposium here at Soho. Here's the faculty for tonight. I'm really happy to be joined by my colleagues and friend, Bose, who's coming from MD Anderson here in Houston. Andrew Kuykendall is coming from Moffitt in Tampa, Florida. And myself, Dr Mascarenhas, who's going to be moderating and speaking tonight from Mount Sinai in New York City. So we've got a great lineup of speakers. It is important to understand that there are study participants in the survey that are not here tonight that helped in responding to the survey, which we're going to highlight through the talk tonight, which includes Aaron Gertz from Cleveland Clinic, Claire Harrison, who's from the UK, and Ruben Mesa, who's now newly down at Atrium Health at Wake Forest. So they have participated remotely as respondents to the survey. So there are a couple of things, a couple of housekeeping slides before we get into the meat of today's presentation. This is the usual accreditation information, which I'm not really going to go through. This is a RTP event, Research to Practice, also in conjunction with MLI, as you can see here. And you can see the support. This is a transparent event, support by BMS, CTI, and GSK. We thank you for that independent support. And of course, here's the classic disclosure and conflict of interest policy, which I am not going to read. And then the planning committee and content and peer reviewers. You can. This will all be available on the slides that you have as well. And then everyone's disclosures for transparencies, including Dr. Bose, Dr. Gertz, Dr. Harrison, Dr. Kuykendall, myself, Mesa. And we will be discussing agents, some of which have unlabeled use, and then the usual legal disclaimer that's there. So let's get right into it, because we do have a lot to cover in a relatively short period of time, so it's going to be quite concise. We're really hoping to highlight the surveys and maybe pick out whether there's controversies or not in aspects of management of myelofibrosis. And I think with that, I'm going to show you the agenda. So clinical decision-making for patients with MF is going to be head by Dr. Bose. I'll go over the management of MF in special patient populations, and then Andrew will take it home with future directions in the management in record time. So let me run through these questions. So this is peppered through the evening where we did a survey. You can see the respondents by their pictures and names and what they picked. And the idea is there consensus or is there controversy in these questions? The first one is, which prognostic tool or tools do you typically use for your patients with myelofibrosis? And you can see that there's really a variety of different answers. In fact, interestingly, Dr. Harrison uses every tool ever created to risk stratify her patients. It must take a lot of time to do that. Maybe I'll stop for a second and ask Prithvi specifically, why the MIP70 plus version 2.0?
Most comprehensive, integrates molecular, clinical, most comprehensive, basically.
So I think key point here is you need the molecular data in order to use that. I mean, I personally picked DIPS because I think it's the easiest one. You don't need all the cytogenomic data, and it can be used, and you could talk about a patient with anyone almost in the world with DIPS. So I thought DIPS was a good one. But you can see that there's definitely variety of scoring systems out there that one can use, and probably not uniform consensus on how best to utilize them. And I would even make the provocative argument that does it really matter? Because at the end of the day, we're really using these to make a decision to either go to transplant if you're higher risk, and have that discussion with the patient, and or in the setting of starting JAK inhibitor therapy, which, you know, I'm not sure if each one really tells us something really dramatically different. Okay, so this is a case, a 75-year-old, fatigue, drenching night sweats, weight loss, abdominal pain, diagnosed with myelofibrosis. Platelet count is 110,000, hemoglobin 11.1, white count 18,000 with 2% blast. So what would you do with this patient? So this is a case we're not going to spend a lot of time on because there's uniformity in the response here. Everyone queried here picked ruxolitinib. I don't think this is really a controversial question. So let's get to the next one. So maybe more important and more controversial is we know we're going to use ruxolitinib. What is the dose we're going to use in a patient with a platelet count of 150,000? And you can see that the doses vary. So I'll pick myself. I pick 10 milligrams twice daily. Why? I like to start low for the most part and titrate up. Andrew, you picked 15 BID. Why 15?
Yeah, I mean, this would be on label, but at the same time, I think, 15 twice a day with a platelet count of 150,000, you're probably not going to drop the platelets so much that you get into trouble with that. And certainly that's a dose that you expect to get good responses, both the spleen and symptoms. And you still have the ability to titrate up or down as needed after that.
But do you have more trouble titrating down than titrating up? Isn't titrating up easier?
I think titrating up or down, for the most part, is relatively similar. I think it really, if you start at a medium dose, I think the worry I have is starting a low dose is if patients tolerate that very well, and you talk about wanting to increase the dose, sometimes they'll have hesitation for doing that. And so I kind of like to start at a moderately higher dose.
Okay, fair enough. Okay, so let's get to the talk. This is by Prithviraj Bose.
Thanks, John. So the JAK inhibitors obviously are the cornerstone of treating myelofibrosis. So I'll be covering the first two approved, Rux and fedratinib. Okay, so this is, of course, a reminder of the pivotal trials that led to ruxolitinib's approval back in 2011, Comfort 1 in North America and Australia, Comfort 2 in Europe, slightly different in terms of their endpoints, but SVR35 common to both, the TSS50 used in Comfort 1, a different quality of life instrument used in Comfort 2, and also in Comfort 2, the readout was at 48 weeks, and in Comfort 1 was at 24 weeks. The results obviously are self-explanatory. And then that was spleen, and here you have symptoms, so about 42% in Comfort 1 for spleen response, 46% for symptom response. Comfort 2 around 32% for spleen at 24 weeks, just comparing apples to apples, and this just shows you all the different symptoms that improve. Now, importantly, we have survival data for ruxolitinib. This is a pooled analysis, 5 years of follow-up of both trials. And the reason you see three curves there is that there's also the RPSFT, or rank-preserving structural failure time correction, because these were, of course, trials that allowed crossover, which obviously can blur the survival benefit. But it's well established now that Rux does have a survival benefit, about a 30% reduction in the risk of death across these trials, and there are other data sets that have shown the same thing. Spleen response correlates with survival. This was shown many years ago by Serge from the MD Anderson experience, but also in the Comfort trials. Spleen response, the depth of the spleen response, the extent to which you shrink the spleen is correlated with the survival benefit from ruxolitinib. Now, there's a lot of questions that arise about dosing, and something that emerged from Comfort 1 was that the symptom response seemed to only require 10 milligram twice a day. That dose seems to suffice for symptom control in most patients, with higher doses mostly not necessary for symptoms. But for spleen, it's a different story. Higher the dose, better the spleen response, and as we just said, the better the spleen response, the better the survival. Cytopenias, of course, are a problem with ruxolitinib. As is well known, you see a nadir in the first 12 or so weeks, and then that improves, and by about 24 weeks, you're at some sort of a new baseline, which is a little bit lower than the original starting point, at least for the hemoglobin. But the point being that it levels off after that, and you see a decrease in the platelets as well. Now, this anemia, Rux-induced anemia, is different from disease-induced anemia. It is not prognostically adverse the way that disease-induced anemia is, and that's just an important point to keep in mind. Obviously, it's a problem for the patients, and certainly can be a burden on the healthcare system, but it's reassuring to know that that is not prognostically detrimental. There are ways to get around this. The realized study was published by Dr. Cervantes a couple of years ago, and this is sort of similar to what John was alluding to, where you can start low, that is 10 milligram twice a day in an anemic patient, and then after about 12 weeks, you can titrate up, and as long as you do that, you seem to not compromise the spleen response. There's also data on platelets, low platelets. This is an important topic because the US label, as you know, only recognizes 5 milligram twice a day as a starting dose in patients with platelets of 50 to 100, or what we would call moderate thrombocytopenia. This study done in Europe, the EXPAND study, showed that 10 milligram twice a day, which many of us had been using sort of arbitrarily, is actually safe and effective as a starting dose in that thrombocytopenic population. Under 50, of course, Rux has not been studied. Now, the earlier you intervene with Rux, the better in terms of both toxicity and efficacy. So higher efficacy, lower toxicity in the intermediate 1 patients, as shown on this slide. Studies like COMFORT 1 and 2, of course, excluded these patients, but there are other studies shown here that have studied intermediate 1 patients. And on that note, we also know this is more recent, where the COMFORT patients were looked at by how long after their diagnosis they started ruxolitinib, and there was clearly superior efficacy and better survival in the patients who started within 12 months of diagnosis as opposed to those who started later. Fedratinib was approved in August of 2019. This is Jakarta. This was the frontline trial, JAK inhibitor naive. 2 doses were looked at, 400 and 500 once a day compared to placebo. The usual endpoints, 24 weeks. And this is spleen as well as symptoms, and clearly a positive trial with response rates very similar to those of ruxolitinib. Toxicities of fedratinib, a little bit of extra baggage there in terms of GI. The cytopenias, of course, are similar to those of ruxolitinib, but in the early first cycle mainly, we'll come to that, you see this GI toxicity, which has to be not necessarily prophylaxed against, but certainly treated ASAP. Encephalopathy obviously was a concern, which led to this drug being temporarily shelved, but of course that turned out to be not nearly as much of a concern as it was initially felt to be, and this is really a very low risk, but most of us have been supplementing thiamine just in case, and of course it's important to check a baseline thiamine level and then repeat it periodically. Now, survival has been shown from Jakarta as well, but remember this drug and this trial, these trials were affected by the clinical hold, and therefore you're not going to get the long follow-up that we have for ruxolitinib, for example. And so here, with the limited follow-up, definitely there seems to be a promising PFS and OS signal. Now, Jakarta 2 was in patients that were previously treated with ruxolitinib. You just had to have received 2 weeks or more of ruxolitinib, and the definition of ruxolitinib failure was left up to the physician. Initially, the median time of prior ruxolitinib was about 10 months, though, and this really showed some remarkable results with 55% spleen volume response at 24 weeks, which, however, came down to about 30% when some stringent criteria for defining ruxolitinib failure, as you see in the middle in the table there, were applied. So 30% spleen, 27% symptoms, again about the best that there are in the second line setting, but not quite as high as initially thought with the last observation carry forward method in the initial analysis. Now, Freedom is the latest trial, phase 3B. This is after the approval of fedratinib, and we are awaiting the publication of these results. They have been presented, but what I'm showing you here is that toxicity signal, the GI, is really mainly in cycle 1, and again, it's important to make the patient aware and treat proactively, and generally this is quite manageable. And that should be it. I think we're going to go to some more survey results, John.
Yep. Let me jump right back in.
Yep.
Thanks, Prithviraj. That was a great overview of ruxolitinib and fedratinib. It takes us now into the next series of 4 surveys with, again, the intent to identify whether there are controversies or commonalities in our responses. So here is a 68-year-old gentleman with intermediate risk MF, dosed with ruxolitinib 15 milligrams twice daily. After 10 months, develops increasing asymptomatic splenomegaly. The platelet count is 150,000, hemoglobin 13.8. What do you do in a patient like this? So 10 months in, worsening splenomegaly, And Andrew says increase the dose of ruxolitinib. Stands alone, almost alone at that. Andrew, why increase the dose, and why not switch to fedratinib after what Prithvi's shown you?
I'd be happy to be alone with Dr. Harrison. So, I think the thought here is you're at 15 milligrams twice a day. We do know that you have room to go up to 20 or 25 milligrams twice a day. We know dose matters, and before switching to a different agent, which can be sometimes a challenging process, and certainly is associated with new side effects from switching to another agent, I would certainly try to max out the dose of the ruxolitinib before making that switch. You can certainly plan on making that switch down the road, but at least understand that you've given that first agent as much of a shot as possible.
Okay. And I know you're also keeping in mind that there is data that Serge Verstafek has published showing that there's a dose dependency with Rux in terms of spleen reduction. But if it was not asymptomatic splenomegaly, but perhaps systemic symptoms, I would make the argument that maybe a higher dose of Rux really wouldn't be the best way. So we'll give you that, Andrew. Okay, here, 65-year-old patient, high-risk symptomatic MF, did not experience reduction in spleen size or improvement in symptoms after 3 months. So sort of, I think what most people would agree is sort of the minimum amount of time you want to try Rux before giving up. Which changes would you most likely try, assuming that you have normal liver function and a platelet count greater than 200,000? And Prithvi, here you picked escalate the dose of ruxolitinib. So maybe you could tell us why that rather than switch to fedratinib.
Yeah, it's just kind of a spin on what Andrew just said, I guess. But here the platelets are higher. There's a solid platelet count over 200. And there, as he said, you can go to 20 and 25. So I think it's mainly the platelets for me.
Okay. Although I have to say, I don't think it would be unreasonable at this point to consider fedratinib in a patient like this, and endorsed by the NCCN guidelines. So here we have a 65-year-old gentleman, symptomatic, high-risk MF with splenomegaly. Baseline platelet count here is 110,000. Receives ruxolitinib at 15 twice a day. He responds with significant symptom improvement and a decrease in spleen size. But 3 years later, he comes in with drenching night sweats, fatigue, abdominal discomfort, and an increase in spleen size. So he clearly has had progression of his disease with initial response. The platelet count remains around 110,000. Hemoglobin's 11.2. What would you do in a patient like this? And I'm going to go back to Andrew, who said he would continue ruxolitinib, but at a higher dose. So Andrew, why that rather than switching to fedratinib in this patient?
If we taped my previous answer, we could just replay it. I think you have, again, platelet counts 110,000. Their baseline platelet count was that much, so it really hasn't impacted the platelet count as much as you might expect Rux would at that dose level. You have someone whose symptoms are worsening, but you haven't maxed out their Rux dose. True, symptoms typically respond at lower doses, and they did. But I think before you switch off and move to a different agent, I would like to see what the benefit would be in increasing the dose of an agent this patient clearly was sensitive to at some point.
Okay. And you'd go to 20, and how long would you wait till you say it's not working?
I think you can certainly do a couple of things at the same time. You can go to 20 or 25 twice a day. You can also talk about, that the next step would be fedratinib. You're going to be monitoring the patient on a, probably biweekly or monthly basis. If symptoms do improve nicely with ruxolitinib, symptoms typically improve quite quickly if they're going to improve at all. If you're not seeing that, then certainly you can pull the trigger to move to fedratinib.
Okay. And Prithvi, you picked fedratinib. You presented the data in the phase 2 in the second-line setting. So just highlight why fedratinib for you.
Yeah, here it's been 3 years. So it's been quite a good duration on ruxolitinib. The median duration of response to ruxolitinib is around 3 years. The platelet count is more soft here. I agree it's not bad, but it's clearly lower than in the previous case. And those results in the second-line setting, 30% spleen, 27% symptoms, are really about the best we have.
Yep, agreed. Okay, so an important aspect with fedratinib that you need to be aware of, it does have a black box warning for Wernicke's encephalopathy. So which nutritional elements must be evaluated? Everyone here picked thiamine appropriately, and the frequency is about every 3 months. Of course, Andrew sometimes says it every 6 months, but we won't hold that against him. And of course, some people will just give thiamine replacement at the start of fedratinib, and I think that I really think that this is an important point just to highlight the fact that Wernicke's encephalopathy, although a black box warning, really shouldn't be a reason to dissuade you from using fedratinib, in my opinion. So those were the 4 questions. We're going to move now into the management of MF in special patient populations, and this is me. Here are the questions preceding my talk. A 65-year-old gentleman with symptomatic high-risk MF, there's a lot here. Platelet count's 110,000, receives Rux at 15 twice a day, responds with significant symptom improvement, decrease in spleen, but then comes back with worsening symptoms and worsening spleen. Here, the platelet count is 44,000, so it's different than our previous question. What do you do here? Total consensus, pacritinib, it's the FDA label, as we'll talk about. I think there's really not a lot of controversy in this one. Wouldn't you agree? Andrew agrees. Next question. 55-year-old gentleman, so younger, presents with fatigue, drenching night sweats, weight loss, bone pain. Spleen is 20 centimeters, which is very large, with significant abdominal symptoms, and is diagnosed with myelofibrosis. So at diagnosis, JAK inhibitor naive, platelet count is 44,000, hemoglobin 8.1, white count is high, 2% blasts, and he's JAK2 mutated, TET2 mutated, and ASXL1 mutated. What would be your management approach? Many of us picked pacritinib because of the platelet count low, followed by transplant. He's young, so he's potentially curable. But of course, Andrew picked momelotinib, followed by transplant. And I'm going to ask you, Andrew, why momelotinib and not pacritinib? And what's your rationale?
Yeah, I mean, I think in reality, both of these are options, right? I think when we look at the JAK inhibitors, we have available. Obviously, momelotinib does not have an approval at this point, but we do expect that to come down the pipeline. Pacritinib is certainly approved with accelerated basis for patients with platelets less than 50,000. This would sit in that realm. But momelotinib also has a pivotal phase 3 study where they enrolled patients with platelets down to 25,000, and has a little bit better as far as prospective data in terms of improving hemoglobin. Certainly, pacritinib has shown kind of retrospectively, looking at the PERSIST studies, the ability to improve transfusion dependency and hemoglobin as well. So I think both are options. I think it's certainly potential a feel thing.
Okay. I mean, I would make the argument that does improving hemoglobin in a patient that you're going to take probably imminently to transplant, does it really matter? I don't know. I'm not sure if it really matters. So I think both are an option. To me, the other thing that you might want to consider is, does the molecular profile actually influence the decision making? And we unfortunately don't have clear biomarker-guided decision making at this point. But I would make the argument that we do have some data would suggest that JAK2 mutation status, the VAF burden, might influence the decision making, where patients do seem to respond to pacritinib across the quartiles of JAK2 V617F VAF. And that cytopenic profile with TET2 and ASXO1 sort of paints an ideal picture for pacritinib, but momelotinib could be an obvious option. So here we go. 62-year-old woman presents with primary MF, symptoms, splenomegaly, baseline platelet count is less than 50,000. What are you going to do? And patient is not a transplant candidate in this case, or doesn't want to go to transplant perhaps. What are you going to do? And of course, Andrew again picked momelotinib rather than pacritinib. Again, why momelotinib in this patient?
I think similar answer. I think that certainly momelotinib studied in this patient population, has a positive phase 3 study. I think some of this comes down to toxicity profile. When we look at the toxicity profile of our JAK inhibitors, ruxolitinib we know very well tolerated. I think all of them are overall very well tolerated, but certainly with fedratinib and pacritinib, we see more GI side effects, more nausea, vomiting, diarrhea. A lot of that can be mitigated with prophylactic antiemetics and supportive care, and certainly guidance on that. Momelotinib, we don't see as much GI toxicity. So in a frontline patient who certainly has 2 options that would be consistent with the trials that have been done, I would probably elect for the one that maybe has less known acute side effects.
Okay. And Prithvi, you want to add anything to that?
Well, I'd say that, they're both very comparable. Both hit ACVR1. Both can be used at this platelet count. But I think there's a little bit more data in the less than 50 with pacritinib.
Okay. All right, excellent. 75-year-old woman, symptomatic MF, receives Rux at 15 twice a day. She responds for 2 years with symptom improvement. But then over the last few weeks, gradual increase in spleen size, hot flashes, fatigue, early satiety. Here the platelet count is 43,000, hemoglobin 8.4, white count is 14,000. And let's say this patient is not a transplant candidate. So an older patient already on a pretty good dose of Rux, initial response, and now looks like it's losing the response, and platelet count is 43,000. What do you do in this case? Andrew, I always go to you. You would switch to momelotinib. There seems to be a theme here. You'd switch to momelotinib. Why momelotinib and not pacritinib here?
This is a very similar patient population that was a candidate for the MOMENTUM study. So patients previously on RUX with some degree of symptoms of splenomegaly anemia certainly would fit within their platelet criteria on the trial. I think in someone who's not a transplant candidate, I'm thinking maybe a little bit more so about improving hemoglobin in that patient population, being able to keep them away from needing transfusions. I think the data, similar to, as Prithvi said, the data maybe in the less than 50,000 is better with pacritinib. I think the data for anemia improvements and transfusion independence rates a little stronger with momelotinib, so that's why I'd go with this patient.
Okay. And let's talk about dosing for a second. So, one distinction is with ruxolitinib, it is dosed by platelet count, and we said earlier on from one of the earlier questions that there can be variability in how patients will dose. They might start low, or physicians will dose low and titrate up, or higher and titrate lower. That's not really an issue with pacritinib and momelotinib, right? It's straight dosing, kind of no matter what, at least with pacritinib, no matter what the platelet count is. And momelotinib has data, at least from the MOMENTUM study, to 25,000, and you use the full dose. Is there a reason why either one of you would not use the full dose of these drugs going in treating a patient?
No?
Okay. Simple. No controversy there. I would agree. I would use the full dose. I mean, even a platelet count of 10,000, Prithvi, you would use full dose pacritinib?
Yeah.
Okay. When do you dose reduce pacritinib?
I haven't had to, but I guess there could be non-heme tox, perhaps, the diarrhea, but then that's usually the first 8 weeks and manageable. Again, I guess I'll have to see.
Okay. Fair enough. All right. So I'm going to talk about MF in the special patient population, and I'm going to try to do this within time. So this slide highlights the difference in kinome profile between the 4 JAK inhibitors, the 3 approved JAK inhibitors, and then the likely soon-to-be approved momelotinib. You can see they all hold something in common. They're all JAK2 inhibitors with relatively similar specificity for JAK2 or sensitivity for JAK2, but there are differences. So, for example, pacritinib does spare JAK1. And if you look below, pacritinib is a JAK1, IRAK1, ACVR1 inhibitor, where momelotinib is also an ACVR1 inhibitor, perhaps not as potent as Steve O reviewed earlier today at the session. And what we don't have here is that FLT3, which contributes to the toxicity profile, is a component of the kinome profile of fedratinib and pacritinib. So you do get more GI toxicity with those drugs you need to be aware of. So we understand that there are nuances in the kinome profile that might explain differences in the activity of these drugs, the ability to use JAK inhibitors from the same class in different patient populations. And here I'm showing you pacritinib, which again inhibits JAK2, spares JAK1, inhibits IRAK1, which signals upstream from NF-kappa B, which has been shown to be potently upregulated in MF, driving cytokine production. So it runs parallel to the JAK-STAT signaling pathway. And of course, ACVR1 has gotten a lot of attention recently because both momelotinib and pacritinib hit this pathway, and this mediates hepcidin expression, which is high in myelofibrosis, thereby reducing phospho-SMAD signaling and enabling better iron availability for erythropoiesis. So understanding the mechanisms of these drugs may help us understand why there's some differentiating clinical aspects and considerations when using them. The PERSIST-2 study was the randomized phase 3 study taking patients with platelet counts less than 100,000, by definition cytopenic. They could have seen a JAK inhibitor previously, and half of them did, and randomizing them to either pacritinib at 200 milligrams twice daily, 400 milligrams once daily, or best available therapy, which could also include ruxolitinib, and 50% of those patients essentially received low-dose ruxolitinib. Here are the baseline characteristics of the patients. I just want to draw your attention to 2 rows here specifically. The median platelet count, the platelet count less than 50,000 was seen in almost half the patients. So this is a very low platelet patient population, a very advanced patient population, very dissimilar, I would say, to what we saw in the COMFORT studies and the SIMPLIFY studies, for example. And again, almost half the patients did receive ruxolitinib, so previously treated. You can see the options on the right there in the BAT sort of highlight the urgency and unmet need in this patient population where low dose of ruxolitinib was used, hydroxyurea was used, and in 20% of patients, just watch and wait. There really wasn't a good option for these patients with extreme thrombocytopenia. And at 200 milligrams twice daily, the drug was clearly effective and superior to BAT arm in terms of spleen volume reduction, shown here, 22% versus 3%. And if you look at symptom improvement, significant improvement in symptom burden as well at 200 milligrams twice daily. And this was even true when you looked at the sickest and worst of the patient population, those with platelet counts less than 50,000. In fact, the results even look maybe even a little bit better in this patient population. So at the 200 milligram dose twice daily, you had superior spleen and symptom benefit over BAT in the PERSIST-2, patients less than 100,000. And even by PGIC, patient global impression of change, most patients were reporting improvements overall in how they felt with pacritinib, and that's highlighted here in this slide, demonstrating that patients either scored very much improved or much improved, whereas in the BAT arm it was more frequently worsened. Now, what was evident in the PERSIST-2, but perhaps more relevant today, was that there is a anemia response with pacritinib, 25% clinical improvement. That means either a 2 gram per deciliter increase in hemoglobin or conversion from transfusion dependence to independence. And even in those patients who were transfusion independent, there was improvements in, or transfusion dependent, there was improvements in transfusion burden with pacritinib. So this was a drug that is also associated with an anemia benefit. We think that anemia benefit is likely attributed to its ACVR1 inhibition, which Steve-O has shown very nicely is even, in fact, more potent than momelotinib, as shown here. And this is not the case with fedratinib and ruxolitinib. So we do expect, and we've come to appreciate, that there is some degree of expected treatment-emergent anemia with fedratinib and ruxolitinib, whereas you can mitigate that and even improve the hemoglobin levels with pacritinib and momelotinib, as shown here. One interesting aspect, and this really drills down to the ACVR1 part. One interesting aspect is at the IC50 of pacritinib, you 100% of the time you are hitting the at the Cmax of pacritinib, you're hitting the IC50 of ACVR1. So you're having continuous suppression of that signaling pathway and hepcidin expression, whereas with momelotinib and its dosing and its PK profile, you get this up and down swinging course where you're not getting this continuous, and that may or may not make a difference. I don't know. It's just a different profile when one looks at it in the laboratory. If you look at the data as it relates to anemia with pacritinib shown here, the transfusion independence rate at 200 milligrams twice daily in the low platelet patient population was 37% versus 7%, so quite statistically significant. And no matter how you look at the data, whether you look at it by previous Rux exposure, depth of thrombocytopenia, or JAK2 allele burden, and I do think JAK2 allele burden does influence phenotype and likely influences response to treatments, it was superior with pacritinib in each case. And this was even when considering that there was a subpopulation of patients in the BAT arm that were allowed to receive ESAs, and that was not true in the pacritinib arm. There was also a sense that with anemia, there was a survival benefit. This is a little bit difficult to tease out because the trial, unfortunately, was stopped early and prematurely due to a clinical hold. And it's a pretty well-tolerated drug. There is GI toxicity, much like fedratinib. It's in the first cycle or two, easy to mitigate with ondansetron or Imodium when needed, and rarely a reason for discontinuation. I would say bleeding is probably a toxicity one needs to be aware of. You can see 14% versus 7%. Patients who have known bleeding diatheses or coagulopathy may be at more risk. So those patients, you have to proceed carefully with pacritinib, if at all. And I would be very careful using pacritinib in patients who are actively receiving anticoagulation with low platelets. Cardiac toxicity didn't seem to be different than the control arm. When you look at risk-adjusted AEs as shown here by Naveen Pemaraju at MD Anderson, so looking at over time, because one of the problems when we look at studies, primary analysis, we're often biasing the toxicity look because there's often a difference in exposure time between the study drug and then the control arm because of the crossover effect. So here, adjusting for that by patient events per 100 patient years, you can see, and I've highlighted with the red box on the right, comparing ruxolitinib, so this is low-dose ruxolitinib in this low platelet population, to the pooled pacritinib experience from the PAC-203 study and the PERSIST study. You can see there was actually lower rates of malignancies, including leukemic transformation, non-melanoma skin cancer. Now, whether this is due to sparing of JAK1 is perhaps an element of debate, but the data does speak for itself, as well as lower infectious risk with viral infections. There were no cases of shingles, and the fungal infection rate was equivalent. The Pacificate study is an ongoing phase 3 study that was agreed upon with the FDA. Less than 50,000 inpatients with myelofibrosis in need of treatment who've received a limited amount of ruxolitinib, and it's pacritinib 200 milligrams twice daily versus physician choice. It is now closed to accrual in the US and is completing accrual outside of the United States. Now, we need to talk about momelotinib. Momelotinib is an old drug, actually. It's been in development for quite some time. And you can see Simplify-1 was the first study in patients who were JAK inhibitor naive. So it was momelotinib versus ruxolitinib. And I've shown you the primary endpoint. Here was 26% of the momelotinib treated patients hit SVR 35% versus 29%. This was a non-inferior endpoint. And then in Simplify-2, it was the patients who had seen ruxolitinib previously and then were switched over to momelotinib or BAT, in which it was mostly ruxolitinib. And here it was low spleen response rates. But I think that was really more of a function of the design of the trial rather than a comment on the activity of momelotinib here. And then the pivotal study that the FDA is now reviewing for its approval is the Momentum study, which was reviewed again in today's earlier session. And these are patients who had received JAK inhibitor previously and continue to have unmet symptom need and anemia. And I'm going to show you that data. So here's the study design for the Momentum study, 200 milligrams once daily plus placebo versus danazol. Why danazol? Historically, we've used danazol as a drug to address anemia. It's not really a drug that addresses spleen and symptom per se. And historically, the response rates are somewhere between 20 and 30% with danazol, mostly as a single agent. So these patients were already on a JAK inhibitor, had anemia, splenomegaly, and symptom burden, and they were randomized to one of these arms. Momelotinib was clearly the winner here compared to danazol for the primary endpoint of total symptom score, which is unusual. Usually it's SVR. As you can see here, and you can appreciate the waterfall plots were in favor of momelotinib at week 24. As well as spleen response. So it's broken down by SVR 25% and SVR 35%. Now, danazol, again, is not really a spleen-reducing drug, so this was a clear win for momelotinib as a second-line agent addressing symptom and spleen. What about anemia? And this is where we saw through the history of the development of this drug was different than the other drugs in terms of its less myelosuppressive effect on erythropoiesis and even anemia responses. So transfusion independence went from 13% to 30% at week 24 with momelotinib, and this was statistically significantly non-inferior, which was the design, to danazol, which was 20%. And what I really like are the curve on the right that demonstrate this improvement in hemoglobin that is maintained in blue with momelotinib, even past in the open label extension phase period. And what's interesting is if you look at the danazol effect, danazol also does improve anemia to some extent. This is mean hemoglobin over the course of the time. But you see that the curves start to meet later on because those patients crossed over from momelotinib, from danazol to momelotinib, suggesting that there is really this additional benefit of momelotinib to anemia. There was even a survival benefit that was seen at 24 weeks if you received momelotinib in blue versus danazol. Again, it was lost, and those curves meet because of crossover effect, but suggesting that there is a tie-in between, and I believe it, the tie-in between JAK inhibition, probably improvement in symptomatology, reduction in spleen, and improvement in anemia that will afford a patient a survival benefit over patients who are not experiencing those effects. This was a pretty well-tolerated drug, and that's pretty much what I'm going to say here. There wasn't a significant toxicity concern seen here in terms of significant grade 3-4 toxicities. Peripheral neuropathy was an initial concern in the development of this drug, but this didn't turn out to be a major issue. And Serge has recently published an experience from 3 randomized clinical trials demonstrating, again, the tolerability profile over time, which is a nice way of looking at it, suggesting that there's not some late effect toxicity concern that emerges with momelotinib over the treatment course. So in conclusion, I think there are multiple available JAK inhibitors that provide better options for our MF patients with cytopenias. Pacritinib as a JAK2 IRAK1 ACVR1 inhibitor can be used in patients with myelofibrosis with thrombocytopenia, regardless of the line of therapy. It is endorsed by the NCCN guidelines, second line, irrespective of the platelet count. We do see anemia responses, particularly in the setting of thrombocytopenia, which is really an unmet need, and pacritinib fills that. Momelotinib is a JAK1/2 ACVR1 inhibitor, also has very nice data now for anemia responses and durability of anemia with a very safe clinical profile. So I'm going to now go to the additional investigator survey results, and then we will finalize our evening with Andrew Kuykendall's presentation. Here is 65-year-old gentleman, symptomatic high-risk MF with splenomegaly. Baseline platelet count is 210, receives Rux at 20 twice a day, because Andrew's treating him, and he responds with significant symptom improvement and decrease in spleen size. But 3 years later, he comes in and he's now transfusion dependent, receiving transfusions every couple of weeks. And let's assume the patient's not a transplant candidate. What would you do? And interestingly, Andrew didn't pick momelotinib for this patient, but actually here said, we're going to continue ruxolitinib and add luspatercept. And why? Andrew, please tell us, why would you continue ruxolitinib and add luspatercept?
Yeah, I mean, I think this is a patient that's clearly benefiting from ruxolitinib, right? So they're having significant symptom improvement, decrease in spleen size. This case does not mention losing either of those things. So those symptoms are well under control. And so perhaps, instead of switching agents, I'd like to kind of retain the benefits you're seeing and then add on something that's more of a direct anemia agent to improve transfusion-dependent anemia. We'll talk about it here in a little bit, but that's really where luspatercept has shown its benefit, is transfusion-dependent patients on a stable dose of ruxolitinib.
Okay, I think this is one of the rare times I would agree with you, Andrew. That would be my approach too. But Prithvi, you picked momelotinib. Symptom and spleen is at bay. Anemia is still an issue. Momelotinib?
Yeah, I think you can argue this many ways. So I think something that Andrew said earlier, I'm going to echo that. I think the anemia data, the transfusion independence data with momelotinib is really quite compelling. I think that's stronger, let's say, than pacritinib's. Now, the other thing to point out here is that while it's true that the spleen and symptoms have not been lost, if you think about Simplify-1, Rux and momelotinib were the same for spleen, for symptoms. In Simplify-1, Rux was better, but in Simplify-2, momelotinib was better. So I don't think we really necessarily know. And so I think with the anemia there, I would make that switch.
Okay. And as we're doing this, I'm keeping an eye on the chat. There are some questions coming in from the remote audience. And one of them has to do with transitioning from one JAK inhibitor to the next JAK inhibitor. And Prithvi, maybe because we left off on you, how do you switch someone from ruxolitinib to, if momelotinib is an approved drug, how do you switch someone from ruxolitinib to momelotinib?
Well, I certainly need to wait for what the package insert says, but my understanding is that the half-life is also quite short, and therefore a taper and an overlap like we do with fedratinib or pacritinib should not be necessary. So as of what I know now, I would switch them the next day.
Okay. And Andrew, if you're switching someone today from Rux to fedratinib, what's your approach?
Yeah, so switching from Rux to fedratinib, we know that fedratinib has a longer half-life than ruxolitinib, and so if you switch directly from one to the other, first I would say on a lot of these trials there's a 14-day washout period. That's not something we would do clinically. Right. That is something to help evaluate the spleen volume reduction of some of these agents independently of the previous agent they've received. But in practice, we do switch from one to the other, and we try to make sure that we're not allowing a period where they're not having that JAK inhibition. And so because of the longer half-life of the fedratinib, we typically taper down the Rux, and then there may be a period of time where you overlap for a few days the fedratinib and the ruxolitinib to allow that fedratinib to get into the system and allow them to maintain that spleen response. Because we know a lot of these patients that even if they're losing a response to ruxolitinib, there's still an impact that ruxolitinib is playing, and if you just abruptly take it off, that spleen will grow.
Okay, excellent. There's another question here from the audience. Why does pacritinib have increased bleeding risk, and does it cause platelet dysfunction or coagulopathy? And I don't know the answer to this. I don't know that anyone knows the answer to it. We just saw it in the trials. We tried to optimize it in PAC 203 to eliminate those patients that clearly come in with bleeding diatheses. We see these patients. There are intrinsic qualitative platelet issues with patients with myelofibrosis, and I think there's probably a pathology that we don't fully know. And we may be blowing the bleeding risk out of proportion too. I don't know that I would say it's a strict contraindication. I am just more wary of it, and it does seem to be somewhat independent of the depth of thrombocytopenia. Let's go for the sake of time. I'm trying to keep us going here. 79-year-old man, symptomatic MF, receives Rux 10 twice a day, but develops severe anemia and cardiac symptoms, let's say palpitations and shortness of breath. So the Rux has decreased very rapidly to 5 milligrams twice daily, with no change in these symptoms, and the platelet count is 77,000. Hemoglobin is low, 6.16. He's in the infusion suite getting his transfusion. And his spleen is 12 centimeters below the left costal margin. He is not going to go to transplant. What do you do here? And everyone, even Andrew, agreed that momelotinib would be the reasonable choice for a patient like this. I'll just to play devil's advocate, Prithvi, why not pacritinib in this patient? 77,000. It may not be by label. Do you always practice by label?
No, but the anemia here is pretty profound.
Okay.
And again, this is above 50. I think momelotinib has good data, more patients in that setting than, say, the less than 50. And again, like I said, I think the anemia benefit of momelotinib is perhaps stronger.
Okay. Andrew, for you, if you have a patient with a platelet count of 74,000 or 77,000 like this patient, would you, in real life, in your clinic, would you use pacritinib, or do you just practice within the guidelines of the label?
No, I mean, I think that the label is there because it's an accelerated approval because we don't have an agent for less than 50,000 platelets, but the data is there for less than 100,000 platelets quite strongly. Maybe you could even make a case for higher than that, but no, I certainly think the pacritinib's, you have to use these agents per the data that they have, not necessarily what the strict label is.
Okay, excellent. 75-year-old woman, MF, receives Rux 15 twice a day for 2 years, has a good response, but now experiencing worsening cytopenias, new onset splenomegaly, and an increased symptom burden, So spleen and symptoms here. Platelet count is 76,000, hemoglobin 6.7. It's not going to go to transplant. What are you going to do? And here, I guess I stood out as the person who picked pacritinib. So yeah, I mean, I think I picked pacritinib, kind of what you were saying. I mean, we have the data from PERSIST-2, less than 100,000, where it's effective, with a 25% clinical improvement in anemia and both symptom and spleen responses. So to me, pacritinib would be an option, although I can totally appreciate where momelotinib would be a general crowd favorite as well. Okay. 65-year-old gentleman with high-risk symptomatic myelofibrosis and splenomegaly and transfusion-dependent anemia. Hemoglobin is currently 8. Assuming the patient doesn't want to go to transplant, everyone here agreed that momelotinib. I don't even know if we can talk about this one because this one is somewhat straightforward. What if the platelet count was 25,000, Andrew? What would you do in a patient like that?
Yeah, I mean, I think, again, platelet count 25,000, you're thinking a little bit more about pacritinib, a little bit more data in this less than 100,000, less than 50,000 group. I think it's tough with momelotinib there. That's right on the border of what was looked at. In reality, I think what's the difference between 25 and 20 platelets? I think that you could argue that momelotinib probably is safe there. I think the platelet data is largely stable with this agent, but I think pacritinib has more support there.
Okay. And Prithvi, just to throw one at you, what if the patient had diabetes and peripheral neuropathy? Would that make you think twice about what drug to use?
Well, the peripheral neuropathy, again, in Momentum and Simplify, those were they were low rates, pretty low rates than some of the data that was previously reported in other single institution trials. But again, Andrew's point is well taken. Again, as I said before, both drugs have a place in this setting. But I think, in my mind, with the anemia, I think I lean towards momelotinib. But yes, the peripheral neuropathy is something I would discuss with the patient.
Okay, excellent. And I didn't think we'd actually do this, but we're going to get to Andrew Kuykendall's presentation, Future Directions in the Management of MF. Andrew, it's all yours.
Thank you so much, John. Really appreciate you setting this up for me. And we do have some time to get through these slides. And so hopefully we'll bring it home here with some future directions in the management of myelofibrosis. And so to put this into context, when we think about future directions of myelofibrosis, I think we have to think about that as far as what are our currently unmet needs? What directions do we need to take? Because where do we need to go? And I would say like the three main future directions, or three major unmet needs we have are really addressing cytopenias, actually improving, effective hematopoiesis. It would be getting deeper and more durable responses than we currently get with our currently approved agents, and it would be getting disease modification, for whatever that means, as far as getting histopathologic remissions, getting complete and partial responses, which we don't see with current agents. So I'll jump right into really the three agents that are probably the closest to impacting the way we provide care right now. And so first we'll talk about luspatercept. So we mentioned that's a little bit earlier, but this is an activin ligand trap that really acts to decrease SMAD signaling and allow for terminal differentiation. So, the preclinical data for this is really that in animal models of ineffective erythropoiesis, you do see increased SMAD2, SMAD3 signaling. I would say the preclinical data for this is much stronger in thalassemia and myelodysplastic syndrome, but based upon this results, we wanted to see whether or not this would be something that could translate to myelofibrosis. And so this led to a very large and somewhat nuanced clinical trial that looked at 4 different cohorts. Really, they were stratified based on whether patients were receiving ruxolitinib and whether they were either transfusion independent or dependent. And so that was the 4 different cohorts: on Rux, off Rux, transfusion dependent, transfusion dependent. And where we really saw a significant improvement was in this group of patients that was on ruxolitinib, stable dose, who were receiving transfusions. And we saw that up to really 26 to 30% of patients were actually able to become transfusion independent. This is a high bar to meet. These patients were requiring multiple transfusions every few months and went to having no transfusions at all over a significant period of time, which is very difficult to meet. And so we could presume that the number of patients actually achieved clinical benefit, they achieved less transfusions, where anemia improvement maybe didn't meet these criteria, is certainly higher than this 25 to 30%. And so really suggests that this, as a pure anemia improving agent, has some promise in the ruxolitinib setting, but also you can see here potentially in some of these other cohorts, transfusion independent, transfusion dependent, not on Rux, but most striking results in the on Rux transfusion dependent population. The next agent I'll talk about is navitoclax, which is a BCL2 BCL-XL inhibitor. The preclinical rationale came from really the idea that JAK2 addicted tumors seem to rely on the ratio between BCL2, BCL-XL, and BIM. And really it showed that actually in a mutant-specific way, the JAK2 mutation actually drives the overproduction of BCL-XL, actually coming up with a way to promote its own survival. This combined with the fact that in primary myelofibrosis we see an upregulation of BCL-XL, we thought that this actually is a more rational approach to bring to patients with myelofibrosis as opposed to something like venetoclax that targets more BCL2. And so looking at this and considering that it's probably more effective to stop this pathway at multiple different nodes with JAK inhibition and with BCL-XL inhibition, it led to a couple of studies, but really this was first the add-on study. So this is a group of patients that was on ruxolitinib that had a suboptimal response, so still had some splenomegaly and symptoms, where navitoclax was added to this. And you can see that there was a 35% reduction in spleen volume in up to 30% of patients who were on ruxolitinib already. And also we saw symptom benefit in a proportion of patients as well. So very impressive results as an add-on strategy to patients who were on ruxolitinib. And this led into the Transform-2 study, which is looking at patients with previous ruxolitinib exposure who have suboptimal response. A smaller arm of this study was the frontline study, which combined ruxolitinib and navitoclax in treatment-naive patients. And here, across different subgroups, you can see this led to a very robust response in over 60% of patients in terms of spleen volume that was really seen across different risk groups, different age groups, and different presence of high molecular risk features. This ultimately led into the Transform-1 study, which is looking at navitoclax plus ruxolitinib versus ruxolitinib in myelofibrosis. This is a study that's completed accrual. The data has been shown out there in some forums, and we'll hopefully see the full data set coming up in the near future. The last pathway I'll talk about is NF-kappa B signaling, and certainly this is something that has gained a lot of publicity in a variety of different forums and certainly a lot of attention. And the preclinical rationale came from really this Maria Kleppi paper from 2018 that initially looked to see how much NF-kappa B was a relevant inflammatory pathway within myelofibrosis. We know JAK-STAT pathway is quite relevant, but here in mice that have received NF-kappa B luciferase, who have either been infected with vector or with MPL mutation, you can see that NF-kappa B signaling it lights up in the spleens of these patients, in these mice, and so it seems to be a relevant inflammatory pathway. It's something that can be inhibited with JQ1, which is a BET inhibitor, or with ruxolitinib, a JAK inhibitor, but seems to be better inhibited when you use the combination. Here you can see histopathologic evidence of spleen and liver responses, where there's essentially normalization of the histology here in the spleen and the livers. And you can also look at fibrosis, where we see rapid improvements with the combination of fibrosis with the combination as opposed to either agent individually. We know that BET inhibition has certainly the role of targeting NF-kappa B, but there's other BET target genes that may be relevant as far as erythroid differentiation and megakaryocytic differentiation. So when you think about this as being something that can reduce inflammation, that acts synergistically with JAK inhibition, that may improve erythroid and megakaryocyte differentiation, you have the promise of a potential agent that could cause a number of different things and may induce disease modification. So ultimately, we have to see what this does in the clinic. And this was brought to the phase 2 MANIFEST study, which looked at multiple different arms, including arm 3, which looked at the combination of pelabresib plus ruxolitinib in treatment-naive patients. We saw impressive spleen response rates of 68%, much higher than what we saw with historical controls of single-agent JAK inhibition. Also impressive symptom responses here. And also quite favorably, when you look at hemoglobin, we saw some favorable dynamics of hemoglobin. When you look here at the patients that presented with anemia, with a hemoglobin less than 10, we see a baseline that's actually climbing up over time. So potentially the ability to improve anemia over time with this combination. Intriguingly, I think a lot of these studies, we have to look at the correlatives, whether we're doing anything to the disease biology. And there were some unique correlatives within this study that looked at the ability to actually space out megakaryocytes. So we know megakaryocyte clustering is a very intrinsic part of this disease. And if you're actually able to normalize that a little bit, maybe that's a better surrogate to look at than things like fibrosis, which may be more difficult to show. And here you can see that actually megakaryocyte spacing was seen and declustering was seen more often in patients that were achieving spleen responses, suggesting this may be a correlate we can use going forward. We know that there's other BET inhibitors that are currently in development from other companies, and I'll just highlight BMS's BET inhibitor here, which has shown preliminary data in combination with Rux and fedratinib. Again, impressive spleen responses in a small number of patients, especially in the ruxolitinib combination cohort. And lastly, I'll show this table really as to say that there's other agents that are in development that maybe aren't as far along, but are certainly in phase 3 studies in a majority of these, and so certainly exciting things coming down the road. We have a imetelstat and navtemadlin in the relapse refractory setting. Both of those are also being looked at as combinations. Selinexor, impressive spleen responses in combination with ruxolitinib. Bomedimstat is an LSD1 inhibitor, and certainly the ALK2 inhibitor that may impact anemia as well. Thank you very much.
All right, Andrew, terrific look to the future. Again, I want to thank everyone for coming in person and for all of the people who tuned in remotely for this consensus and controversy in practice patterns in MF. I'm Dr Mascarenhas on behalf of my colleagues here. Thank you for attending. Have a great evening, everybody.